So week 6, week 6, we got a bunch of stuff that we've got to do again. Remember to get your diagnosis in for your pediatric assessment project. Now, you're going to see that, on Module 8, there are a bunch of topics that you can use. You don't have to use them. Any diagnosis that can be a child's diagnosis is what you want to use, okay? I have people doing strep, and then again, it can lead into a strep is a big bad disease that we treat at it, and it can go more than that. So you do have another case study. It's the hematology case study. It's your system chart.
Your internet is buffering.
How are you guys liking those symptoms?
You're going in and out.
Quality is real bad.
We can't hear you.
Wow, that was something else, wasn't it? I apologize. I've got 3 different devices trying to keep my internet from having issues, but I guess today at this time it's going to be a problem. But I will come back and get you what you do need. All right, let's just go directly into what we need to do today. We're going to do our PowerPoint, and we're also going to be doing the 2 Kahoots. Yeah, I just got a message from someone. Thank you. Whenever you see something going on, somebody text me. I don't know who it is, but thank you. Just let me know. And I can imagine who it is, probably, because they're smiling big. But yes, thank you. Also, if I get cut off, no, I will come right back. All right. I'm not going to leave you alone because you need to get your information. Okay, week 6 of that case study, I was asking, do you guys, you did your first one last week. Do you like them? Or you just find them time consuming and it's hard to work with? Your input helps us get these programs changed.
Very time consuming.
Do they help? Do they give you knowledge at all?
I just feel like they're busy work.
That's what
Yeah.
I feel too.
I feel
You
like
really-
it's just
All
busy work.
All right. No, I appreciate your opinions. You're allowed to give me your opinions. It doesn't go to anywhere. I keep the opinion and I try to go through the powers that be to try to make if there's other changes that could be better, that are less busy work and more getting you all that information you need. Okay. I'm going to try for you. All right. You like the CJ Sims. Somebody was just saying, what happened? CJ Sims we had, and I did like them myself. Something to do with the whole support went away. The program wasn't supported by any technical backup. So it ended up a program that was online, but no support. And we can't work like that when we have to go in and make changes or see errors in it or need a grade that, it didn't, come over, be able to find those things. So that's why we got out of CJ Sims. That's the reason, only because they weren't working right. And if you were that student who did it, you did the CJ Sims and then can't find the grade, it is very frustrating for you and for us as the professors, okay? And that's why the change was made, for no other reason. Not that we didn't like the product, but it wasn't supported for us, for you students, to get what you really need in the long run. All right, let's go and start with our PowerPoint. Yours might look a little differently because I like to play with these things and make them prettier and add just pictures most of the time. Pictures are something that I think tell 1,000 stories with a little picture. So I like showing you things with a picture. So that's the only thing different. All the information is the same, okay? So hematological immunological dysfunction. So how do you go and how do you evaluate a hematological function? And it starts as simple as a simple complete blood count, right? Then let's go ahead and let's talk to that child and that parent. What's going on? You brought that child here for a reason. Why? Is it that lack of energy, being tired all the time, just look pale? All of those things could be part of that reason. Now, one of the things with toddlers is we know that they get as infants and they eat anything and everything, right? They get to be toddlers and now they don't like food, they don't like the taste, the texture, and they only like a certain couple food groups, so they become picky, picky, picky. Well, what that does, it decreases the amount of intake of nutrition, but usually it affects that iron that's coming in because usually toddlers don't like to eat the broccoli and the green leafy vegetables and the protein and some of the dairies, right? They just don't like it. So it could be that. Also, immunological dysfunction. We would be asking, has your child been sick recently, frequently? How much? What is it? Because we know that if your immune system is depleted and not working right, you're going to show it as an infection somewhere. And then the other hematological is all about bleeding. And there's many different ways. It's not just hemophilia that you think about with bleeding. There's a couple more things in there. So let's talk about red blood cells. Red blood cells carry hemoglobin around to the body. Well, what is hemoglobin? Hemoglobin is where you carry the oxygen around in your body. It also carries iron around in the body, and this is important because we're going to get to some other diagnoses here. But when you have iron deficient anemia or any of those anemia, all it means is the amount of red blood cells is decreased, which means you have lack of oxygen, you have lack of iron, okay? Now, we could have the reason be because it's sickle cell or thalassemia, which is cell shape, which is telling you there's something wrong there. Also, when we talk about anemia in children, we don't talk about less than 12. If we give them a little bit more leeway, it could be 10, 11, and that's fine for children. And as long as they're not symptomatic. Well, what would be that symptomatic thing that you would see if you have low hemoglobin in a child? They have no energy. Fatigue. Fatigue would be the big one. So let's talk about anemia in the body and what you would see. So it's a great picture. It shows you when it's normal, all the cells in there, they hold together and they swish through the vessels and you don't hear noise. When they are so far apart, they tend to hit off of each other. And this is the child that if you listen to their heart, you're probably going to hear a murmur if it's low enough because it's swooshing in there because the cells aren't holding all of that fluid together, okay? So that is one of the things I will always listen to when I see a child with low hemoglobin hematocrit. What does their heart sound like? Is it hitting that I can, hear it with a murmur yet, or we're not there yet? When a heart sees that a body doesn't have enough oxygen, what is it going to do? It's going to start producing more red blood cells and it's going to beat harder and harder. And it's going to try to get the oxygen and iron around to the body and it's going to fail. And that's when cardiac failure will ensue. We know if you don't have oxygen, you're going to be cyanotic, which is lack of hemoglobin, which is anemic. And of course, we're not feeding the body. They're not getting their oxygen and iron. You are going to see growth retardation. Absolutely. So types of anemia. This is a picture out of your book, but it is a good one. And it really shows you all the different types. So we have decreased red blood cell production, increased loss, or increased red blood cell destruction. So when we're talking about a decreased production, that's usually nutritional or it's something to do with the bone marrow. It's not putting out enough cells, right? So nutritional, probably the most common, iron deficient anemia. How do you fix iron deficient anemia? you give more iron foods to the baby, right? Or B12 deficiency. Again, it's that intrinsic factor. It has to do with digestion. And if you don't have it, you're going to be with depletion of B12. Now, how do you fix that anemia? Who you give B12. It's as simple as that, okay? Now, when your bone marrow does not work, or not work completely the way it should, there's several things it could be from. One is called aplastic anemia. We're going to go into that in a little bit and what that entails. You could have also, I could say it's the leukemias, the ALL, the AML. This is where white blood cells and red blood cells and platelets are all destroyed. So we'll talk some more about that. Of course, decrease in red blood cells could be just you lost them because you are, bleeding out of your nose, or, you have these other conditions. Hemophilia is the big one. You're missing a factor. That's why you bleed. You get cut, you're going to bleed, and it could bleed up to an hour after the cut. And then ITP is the other one we discuss here in this chapter about hematology. It's idiopathic thrombocytopenia purpura. Say that 3 times quick. ITP is easier. And all it is lack of platelets. Remember, ITP, P is platelets, lack of platelets, and we're going to see bleeding, okay? Let's keep going. I'm going to go into that more. Increased red blood cell destruction. Sickle cell anemia and thalassemia are both red blood cell problems where they die quickly. Sickle cell is a sickle-shaped cell. I'll go into that more. Thalassemia, I call this my rectangular-shaped cell, and we'll go into that more. This G6PD is actually there was one mention in pharmacology and a little note about G6PD. And what it is if you drink or have sugar, your red blood cells will burst. Too much sugar. And I learned this actually. I had a parent who needed me to medicate her child for a fever, but they needed ibuprofen without sugar in it. And I went, huh? I don't know they make that. They go, yes, my child is G6PD. I said, if you mind, could you tell me what that is? And the woman did. She knew exactly what it was. And it was all about the sugar, and that the ibuprofen would go in, get the red blood cells, and they would hemolyze or burst. Okay. Then we have the just normal extra things, like you're on radiation, you're on chemo. Those things are going to absolutely burn up your cells for sure, or some sort of immunological attack on your body. Those things, absolutely. So you get a kid who has anemia of some sort. You've done your history and physical, and then you've done your first basic CBC. So now you're going to get some sort of answer what's going on, right? Now, we might give a transfusion, okay? Or we may not. It depends on the reason for the anemia. If it was due to when they're bleeding out a lot of blood, that will absolutely need some blood to replace that thing. But if it's nutritional, we just need to replace whatever nutrition is they're missing, whether it's iron, the big one, B12, and those things will replace, and it will be a slower thing. It's treat the cause, don't treat the symptom. You'll hear me say that all the time. Treat the cause, don't give me the symptom, okay? And you'll hear that again as we go further here in this week. So supportive care for anemia. Well, this child's got low oxygen, low iron, no energy. That's what they look like. So bed rest. Let them not expend any energy for any reason. Oxygen may or may not help. Okay, less blood cells carrying less oxygen. You might increase the oxygen, but it may or may not. That was one of the controversial things, but put it on, it can't hurt. And then, of course, if we're really low and with volume in the body, we're going to have to do something to replace that intravascular volume, give them some normal saline. Now, I'll warn you, if you have a child who already has a low hemoglobin of 8, and you give them extra volume of just fluid, that number is going to drop more, just to warn you. It's a big concept there. So one of the assessments when we're looking at anemia is the age of the child and the racial or ethnic background. We know sickle cell is ethnic background is going to be, the African American, right? We know that thalassemia is going to be Mediterranean descent. So very important we know that. Of course, do that history, find out what's going on, how long it's been happening, and what you're seeing, okay? And then, because you have to rule out the cause, not the symptom, let's make sure it's not just a GI bleed, right? As simple as doing an occult blood, making sure they're just not bleeding from their GI tract, it's not other nutritional, any other sort of anemia. Now, preparing your children for exams and tests are important. Kids don't like needles. They're going to have to be stuck to get the blood test here. They're going to have to get IVs, maybe for transfusions, maybe for just base overall management and fluids, right? And when children are anemic, okay, with any disease, you always prevent your complications. So as I mentioned a little bit before, it's children don't tend to eat the proper things, especially your toddlers, right? Now, have you ever wondered why we give iron fortified formula or iron fortified cereals to infants? We're trying to build up their iron level, their hemoglobin before they become toddlers. So we are trying to give them everything they need in order to have all that energy and to prevent these iron deficient or any type of dietary deficiency anemias, okay? Now, premature infants are smaller. They tend to require the same amount of calories. Remember, with them being smaller, we still got to get that nutrition in them. So making sure that we give that high calorie formulas, whatever they need. Adolescents, you don't think about them as being a risk for anemia, but think about you as an adolescent. I know me as a girl, you're always too fat, you're never skinny enough, so you skip meals all the time, you don't eat right because you want to be whatever your idea of perfect person is. And again, remember that beginning of adolescence, what do? That first 2, 3 years, we're growing crazy. This is the second time in your life and the only other time besides infants that you grow so quickly. So between not eating right and growing so fast, many adolescents become anemic. Milk babies, this is when you're feeding a baby just milk and you're not feeding them formula. They're not getting what they need and it can cause a lot of problems. So we don't want to just feed whole milk to these infants. When do we give whole milk to an infant? At what age?
1.
Year.
At 1 year old, yes, it is. At 1 year old, we start it, and then they can be taken off their iron fortified formula. And again, just trying to make sure that they're going to get all the nutrition and the iron and all of the nutrition they need from their food. Okay. So with these children, again, it's diet, 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 trying to get them what they want, and then iron supplementation. Now, iron supplementation on children. There was something that you learned in pharmacology, and they tell you to drink iron. It's usually liquid for children. Make sure they drink it through a straw. It's going to stay in their teeth, okay? Make sure you give it on an empty stomach because they need the stomach acid in order to break it down to make it usable for the body, okay? And please tell that parent and the child that their stool is going to turn tarry, black looking, and not to get scared. It's absolutely normal. So you need to know how to give iron. So sickle cell anemia. This is one of those that's a different shaped cell and it's in a sickle. If both parents have only the trait, they don't have the disease, only the trait, every child has 25% chance of getting sickle cell anemia, okay? Only the trait they needed. And then your child has 25% chance, 1 in 4. So let's look at sickle cell. Now, sickle cell anemia, you think of a child who's in pain, right? That tends to be why. Now, sickle cells flow through the body and they come through these bifurcations in the vessels. So a big vessel comes into two smaller, comes in four smaller, and it gets smaller and smaller. And what happens is these sickle cells get stuck at a bifurcation. And blood can't go down distally, down to the toes, down to the feet, down to the fingers. It can't get there. So what happens? There's a backup dam and it keeps going back and you see swelling, redness, and it is extremely painful. Okay. So you get a child in to the, let's say, the emergency room. That's the last 10 years I worked was in an emergency room. And you get these children in with sickle cell anemia. And the cause of the sickle cell problem is that the cell got stuck somewhere and it's not letting blood flow. That's the bottom line. So what are you going to treat it with? What's your priority treatment? Fluids. Let's
Hydration.
dilute, let's make those vessels big, let's get that blood going through. Now, in the other hand, I have my pain medicine, but I'm putting up the fluids because that's my priority, and I'm giving pain medicine because it really hurts. So, why do children have these sickle cell crises? Well, stress will always be up there with any immunosuppressive disease, any of them. Okay. Anything that increases the body's need for oxygen that could be going up in an airplane, right? Things like that are things that you don't think about. Trauma, infection is always a big one. Fever. What do you get? What do you happens with fever? You're always becoming dehydrated, right? You need to constantly having slow slips of fluid to keep up with the fluid balance if you have a fever. If you have a fever, you take an antipyretic, you sweat, you lose fluid, you need to drink. Okay, so that's part of it. So with that increased blood viscosity, it's going to always buckle up those sickle cells. It's going to cause it and cause hypoxia. And, it is painful. We are testing for this before babies are born, so parents are aware. So, child's in a sickle cell attack. First thing, well, first of all, have them sit down, right? Relax. That's always rest. But your priority, hydration with IV therapy, normal saline ringers, lactate, D5.5, whatever they want. They might want to give a bolus of normal saline and start a maintenance, but they need to have fluids going. How else can we dilate that vessel to get that open, to get those blood cells moving along? And it's as simple as heat. Put heat on that child. So you put heat on, you are flowing hydration in there, blood vessels are getting big, that sickle cell impaction of blood vessels is now starting to flow away, and the pain's going to start coming down. Now, sickle cell children, their cells die very quickly. It is not uncommon to have a child come in with a sickle cell crisis with a hemoglobin of 6 or 7. Not uncommon at all. And if they're 6 or 7, they will be getting a blood transfusion. In fact, in the emergency room, this is the one time we will absolutely give blood to the child because they're that low of a hemoglobin and they need it as quick as we can do it. The other thing we do is if they're in a sickle cell crisis, usually it's due to a little infection too. We're going to make sure that they do get their antibiotics and give them IV antibiotics. We really need to treat it aggressively. Now, we do give, it's PenVK is what I've seen given, just one pill or one dose every day prophylactically, and we start about 2 months up till about 5 years old, and that's just to try to prevent infections so we don't have sickle cell attacks due to infections. We do monitor the retic counts, making sure, is the bone marrow working? Are my cells being produced the way that I want? And then, as I said, blood transfusions, because it does reduce the ischemia and it puts blood oxygen around to the brain where you need it, right? So prognosis. Well, there is absolutely no cure for it. Once you have it, you have it. They do think maybe a bone marrow transplant. I've seen bone marrow transplants that did okay, and I've seen some that there was really bad rejection going on. So again, it's one of those do I, don't I type situations. Of course, this is all supportive, giving that child what they need during those sickling episodes. And we know that this is your immunosuppressed child. They are going to get frequent infections, and we have to be aware of it. And that's usually why children die with sickle cell, from the infections. They don't have a system to fight off the infection. But these children can become adults as long as they're aware and get treatment early. So early intervention is the big thing. I mean, I found this picture on the bifurcation of cells and how those cells get stuck. And it's very easy when you see that visual sitting there, right? So another thing, child needs to get their prophylactic antibiotics. And then something you don't think about. You can have sickle cells in your brain. So that's a stroke. You can have sickle cell crisis in your lungs. It's like a pulmonary embolus. If you have those signs and symptoms, they needed to be treated aggressively, okay? And to be watched for closely. These kids, as any child with any sort of illness, they need to be treated as normally as possible and keep active as possible. But they must maintain hydration. If they're out in the cold, they must put warm clothes on because the cold can stop circulation and cause sickle cell attacks, right? If they go in an airplane, extra fluids before they get there. So again, it's being aware what you have and before things happen, treat it. So thalassemia is my other cell that's a weird shape. I call it the rectangular shaped cell thing, and it's thalassemia. Again, shortened life of red blood cells, and they burst into the bloodstream, and this is the problem. Again, as I said, it is from descendants from the Mediterranean Sea. Now, there's 4 types of thalassemia. I don't ask you to know the 4 types. What we usually test on when we're talking about thalassemia is thalassemia major or Cooley's anemia. This is the one where there's no treatment but transfusions. As I said, these blood vessels, these blood cells burst and die quickly, and they need transfusions to survive. That's all they can do. So at birth, we don't know they're thalassemic. We don't know yet. They still have mommy's red blood cells. They're still round shaped. They still look good. But about 6 weeks of age, they start to change. And the reason why we start to look for it is because they become pale. Cognitively, they're not where they should be developmentally or anything. They're not growing. That's telling you, let's go looking what's going on here, okay? Now, again, why do we treat with blood transfusions? Because you need new blood cells and the body can't keep up with it. And the cells that they're producing are going to die. Now, what is the big complication with thalassemia? Well, what's inside a red blood cell? Iron and oxygen. So number 1, you're going to have to be aware, maybe they need to be placed on oxygen for things that take a little bit of energy. They might, but the one thing is iron is being spewed in the body, and too much iron in the body can cause up to seizures and death. So we need to be treating and getting rid of that extra iron in the body. There are oral medications, and then there's which called deferosamine or desferal. This basically takes the iron, holds it, and just excretes it out the kidney. So it's gone. Now, sometimes there's so much going on, or you're in such a high level of iron, they might do something which is similar to your dialysis. It's called apheresis. And they could just pull the iron out of the blood, okay? Because too much iron, again, it causes seizures and it causes, problems with the brain. So one of the things with thalassemia, it is an everyday affair. These children are constantly getting poked with needles, getting blood drawn, getting transfusions. It is really a hard type of diagnosis to live with. So we need to, because of the iron spewed in the body and the danger from it, we really need compliance with the transfusion and chelation therapy. I mean, if we don't get transfusions, our hemoglobin are going to be 2 and 3, and you don't live on hemoglobins of 2 and 3, okay? And then chelation therapy, we need to keep that iron level down to protect that brain, okay? So the other problem is now we're getting all of these blood transfusions. Now, we know blood transfusions are safer than ever, but sometimes blood transfusions have different antibodies and stuff in them. And then it becomes really difficult to find your type of blood with that stuff in it to get a transfusion. So that's the big deal with the blood transfusions. And of course, the normal everyday, any blood transfusion can cause a problem. So always be aware. And what happens if you have a blood transfusion reaction? You spiked a fever or a rash, whatever. First thing, turn it off. Turn it off. It's always number one. Turn it off. Get rid of it. So prognosis. Well, they usually, if they are really diligent, can live into adulthood. Many patients want to stop the progression. So they feel if we stop producing these blood cells that are going to be dying and are not good for the body, they do a splenectomy. Sometimes because they are immunosuppressed, they have post-splenectomy sepsis. So that's the problem. And then it goes into multi-organ. And then heart disease will definitely be a problem with any child that has big hemoglobin, loses it, low hemoglobin, big hemoglobin, low hemoglobin. The heart is beating fast, slow down, speed up, slow down. It can't keep up with it, and it goes into heart disease failure. Bone marrow, again, may be a cure. Where did I go to there? Sorry, I don't know where that happened. Okay, aplastic anemia. Aplastic anemia is something, and we usually, when we talk about it, is a pancocytopenia, okay? There is a profound anemia with low white blood cells and low platelets. Leukopenia, low white cells. Thrombocytopenia, low platelets, P platelets, okay? So you have a child who's going to get infections, no energy because they're anemic, and they're going to have all those other bleeding things because of their platelets aren't there too. Aplastic anemia, we treat very similar to leukemia. We go in there and we try to attack the cells and trying to make them being produced the way that they should. So defects in hemostasis. That means you're bleeding for some reason, right? So we're going to look at the platelets and clotting factors and stuff like that. So hemophilia, first thing I think about when I think of bleeding. It is a hereditary disease. It's X-linked recessive. Mommy gives this disease, okay, to the child. Now, there are different types of hemophilia. There's hemophilia A, hemophilia B, and something called von Willebrand's disease. And all it's telling you is what factor is missing from the blood that's making that patient bleed more than it should, prolonged bleeding time. Now, hemophilia A is factor 8, most common that I've ever seen. Factor 8 is usually when you see hemophilia. Factor 9 or Christmas disease is less common. I've actually seen quite a few of von Willebrand's disease. And von Willebrand is actually just the name of the scientist who found the clotting factor, which helps with clotting. That's all what that name is all about. And it's not only that factor they found in combination with factor 8. So, evaluating for hemophilia. So, we need to know what sort of bleeding's been going on, right? Is it just epistaxis, nose bleeding, or are there abrasions and cuts where there's bleeding quite a bit? Or this hemarthrosis, blood in a joint. What does blood in a joint do? It destroys the joint capsule. And by the time they become older, that joint's not going to work anymore. So we want to prevent hemarthrosis, right? Whether it's elbows, shoulders, knees, ankles, wherever it is, we want to prevent that from going on. And we know any obvious sign of bleeding would be ecchymosis for sure. As I said, it is X-linked. Now, you get a child in, not always are they diagnosed initially. We don't know. It's usually later on in life, okay? And what we'll do is we'll do a bunch of labs when they first come in. They'll do a PT, PTT, they'll do parathyroid, fibrinogen, all of these different factor 8s, la, la, la. The only thing that we are going to get immediate results from are our CBC, which holds our platelets, and we also can do the PT, PTT. We'll get those. So if we see a prolonged PTT time for no obvious reason, that is our first idea of what's going on, because that factor 8, 9, the other lab results, they're sent out special labs. Usually it's 7-10 days later we get the results. So we have to base it upon what do we see. Prolonged PTT is going to be hemophilia, but look at that. Their platelets are normal. So those are the things you would see. So how do we treat hemophilia? Well, if you're bleeding, whether you fell down, hit your knee, and the knee's filling up with blood inside the joint capsule, something needs to be done. So children and parents are taught about a home infusion, and they are taught how to start an IV, how to mix up the medicine, and how to give it. I actually had a little, was it 8 or 9-year-old boy, came in with his father, and he had basically fallen down, and his knee was swollen and ecchymotic, and he didn't know if he should give this factor. He called his hematologist. He didn't get a result, so he came into the emergency room. He asked our ER physician, and we said, go ahead and give it. Well, he brought the factor with him and all of his supplies. And he said, do you mind if I give it? And I'm like, absolutely not. You give it at home. Why would I stop you now? I said, would you mind if I watch you and I had an orientee, a brand new nurse with me? Would you like, is it okay if we watch? He said, for sure. I said, okay, show me what you got. This gentleman did it as good as me, and I'm pretty picky. He washed his hands, he put out the stuff, he used the alcohol appropriately. The boy himself chose the vein the father was going to use, and it was just a butterfly. So he had the little wings to put it in. And the boy himself held the IV in as the father had already mixed it up, put it in a syringe, tubing, and very slowly pushed it in. It was the nicest thing. A 9-year-old kid was helping his father. They got it done, and it was done without any, worries from the kid. And kid got what he needed. Now, that's when you have an aggressive hemophilia. Sometimes you have what we call a mild hemophilia. And sometimes we can give something called Desmopressin, vasopressin. Sometimes it's IV, sometimes it's by nasal spray, but that can be used. At home, what do we teach a child to do if they see bleeding? Well, let's go back to that little 9-year-old who fell down and he hurt his left knee, right? Well, what do? We do rice. We put the P on when we learn it truly is hemophilia. But first of all, they need to sit down, rest. One of the things with rest, I would say, is if you were there or the parent was there, calm them down. Because if they're bleeding, and they are nervous and excited and scared, their heart's going to beat faster. They're going to bleed more. So sit them down, relax them. If you put ice on it, it constricts the vessel. And then you compress it within like an ace bandage and you elevate it. And that usually helps with all of the extra blood going into that joint and can prevent those crippling effects of bleeding in the joints because it will destroy the joints. And the reason why we put the P there is it's protecting. When you have a toddler who's a hemophilia, has hemophilia, this is a child that you would protect them from anything that could be sharp, could be the side of a coffee table or a dining room table or something that has sharpness. This is where I tell them to pad the world. So if this kid bumps into it, they get a bump. They're not going to get a cut. Prognosis is pretty good, actually. They are working on a gene therapy. It's not there yet, but we're starting to work on that factor 8 because that is the one that we see it most of. Now, ITP, immune thrombocytopenia purpura. When you see this, think of P for platelets. Thrombocytopenia, decreased platelets. What do platelets do? They help with bleeding, right? If you don't have platelets, you're going to see signs of bleeding. Now, ITP, when can we get this? Well, it's usually acute. Usually it will not be a chronic or last unless we can't get rid of it for a year. And then we'll say, okay, now you're chronic. But usually it's acute. It's usually following some sort of upper respiratory, some sort of infection. What we'll see is a child, and I've seen it a few times. I've seen them come in stating they've had nosebleeds, they've done treatment, and they continue having every other day they're having a nosebleeds. Or my kid doesn't go outside, doesn't play anywhere. And then you're seeing this purpura sort of rash and bruising, ecchymosis areas. Like, where do they come from? We don't know. So what are we going to do to diagnose this? Well, we're going to do a CBC and we're going to look for that platelet count. Usually it's less than 20,000. It should be 100,000 at minimum, okay? Sometimes it just goes away supportively, but sometimes we're going to have to give IV immunoglobulins and then something called anti-D, and those two together will help. Now, as a nurse, what is your nursing care management? Well, number one, it's bleeding precautions, right? Supportive, making sure whatever they need, if they have a fever, give them a Tylenol or ibuprofen, or if they're bleeding, of course, apply the pressure. But avoiding venipunctures, right? You don't want to stick an IV in that child unless you need one. And we're going to minimize the amount of times we need to stick that child. We're going to watch for bleeding, the gums, stools, urine, look for ecchymotic areas. We're going to be doing blood counts, usually daily, checking on those platelet counts, seeing is it coming back up the way it should? And then they say sometimes, just say corticosteroids, because every time I've seen them give steroids, and that does help with the platelets. Now, epistaxis, I've already mentioned it once, and it's one of those things that can diagnose hemophilia. It can diagnose ITP. It can diagnose one of those things. This is bleeding from a place that normally you shouldn't. Now, it's usually once they get it, it goes away. Well, if they are getting them more frequently, that's when you need to look. Now, how do we treat a child who's having a bad nosebleed? I love this picture because it says it all. If you sit them forward because you want the blood to come out, you don't want it to swallow. Thumb and forefinger on the bridge of the nose, hold it for 10 minutes. If it is still bleeding when you're done, they need to go get care at the ER, to the doctor. Usually, sometimes they have to cauterize it. Something else will have to be done. Sometimes they actually put in nose tampons, and it basically just puts pressure up there. HIV AIDS, now we're into the immune, right? HIV AIDS is babies that are born from an HIV mom, or it could be that adolescent whose risky behaviors, not using protection. We do talk about the infants. We know that if we start this highly active antiretroviral therapy, or HART, we can improve that newborn to soon to become newborn's immune function. We're going to start at about 22 weeks of gestation. And that's going to help support that body because, again, we just want to make that immune system on that infant as strong as we can. Now, I wanted you to know that just because they have HIV from their mom, I have seen them convert at 1 year old, and they're not if they're getting proper treatment. Another thing I've seen with HIV, AIDS, and a pregnant woman, I had one who had triplets, 3 babies. One baby had AIDS, one baby had HIV, and one baby had absolutely nothing. Yeah, I don't know. 3 infants, 3 different outcomes at birth. Okay. So we'll be giving that antiretrovirals. Our goal again is to improve that immune function. And the most common thing that these children get, these infants get, is PCP, or pneumocystic pneumonia, where the lungs are just full and they're just horrible to clean up and they're really in respiratory distress. Usually we're starting to see these symptoms right about 3 to 6 months of age, okay? Now, how do we treat all of these hematological, immunological disorders? We talk about giving what they need. So, blood transfusions. Blood can be PRBCs or whole blood. Whole blood is when you need extra volume. PRBCs is when you need extra cells, not extra volume. Platelets. ITP, we don't give platelets. We let the body support itself, believe it or not. That's not something we would give there. And we know with blood transfusion, there's always a policy. Always follow it. I know at the hospital I worked, is you took vital signs before, you hung the blood, and you came back 15 minutes later and you took them again. That's when I usually found some reaction. And usually it is a fever, is what I found. I've seen a rash, but most of the time I've seen a fever. And again, what do you do first? Turn it off, get rid of it. It's not good for that child. I've mentioned apheresis before, like we could do chelation therapy with apheresis. We can remove certain components out of the blood. You don't just, filter like dialysis filters all of the, debris. Apheresis can say, all right, we need to get the iron out and just do that, okay? We also can use platelets. Just get platelets out of patients and just give platelets back to them. One of the things we can do when we're looking hematologic problems and we're looking at bone marrow production and the way it's working, right? So we do bone marrow aspirations. Has anybody ever been there to witness a bone marrow aspiration with that little blue thing down there? Well, on the end of that is a very large needle, and they numb the area and they numb deeper. They take it and push it in and go, and it pops into where the bone marrow is being produced. The sound is grinding and it hurts. One of the things with children, and I've said it before, like with removing chest tubes, whenever you're doing anything that's going to hurt them, be honest. Let them know it's going to hurt. Make sure that they um, are aware that you're going to give them all the medicine you can, and you'll hold their hand or whatever they need to help them feel better. But children, remember, don't lie to them. Be honest. So when both parents have a sickle cell trait, what is the chance that each other children will have sickle cell anemia?
25.
Hey.
It is. It's 25%. All right, let's go to our Kahoot. Hold on. Who wants to win a Kahoot today? Who from Professor Becker wants to beat the Bogart class? Come on, let's put one against the other. Let's see who wins, okay? It's a new one. There's some old questions, but it is a new. I wish you luck. Again, these Kahoots are a great place for you to go back and look at concepts for exams and for quizzes, also for your HESI and your NCLEX. These are great tools that I have given you. And yes, I make them. It's me. I did it. I'm going to get some water. Okay, let's get going. I wish you luck. Hematology. What is priority treatment for a newborn of an HIV positive mother? I think that's the last thing I talked about, wasn't it? And the whole thing is to improve the infant's immune system. Now, HIV is a virus. What's an antibiotic going to do? I want you to think of these things as you look at questions, okay? Probably one of the most common mistakes is thinking the antibiotic. So, HIV, you're born with it. What we need to do is to improve that infant's immune system so that we can get rid of it. What kind of hematocrit would someone with sickle cell have, and why? Sickle cell, are they high? Are they low? Why? So, sickle cell children have lower blood cells. Remember, I told you I've always see children come in with very low hemoglobins in crisis. They could be 6 and 7, and I'm giving blood transfusions in the ER because they die so quickly. Okay, it is lower, and it is because they die so quickly, those cells. What is the nurse's priority with a child with sickle cell disease and who is currently experiencing a crisis? Priority care for sickle cell is, as in, what do you do first? And I'm telling you, every single one of those is an answer for care for them. But which one is number one? And it's okay. You want to give morphine. You're treating the symptom. What's the cause? The cause is the vessel is smashed up with cells and blood can't get through. Let's give the bolus. Let's dilate the cell. Let's put heat on it. Let's give antibiotics as an infection. And of course, morphine is in my other hand as I'm putting up that IV fluids. Very important concept here. Sickle cell crisis, priority, administer a bolus of fluids, dilate that blood vessel. Let's get it moving. What is the reason children with iron deficiency anemia are easily tired? So, iron deficient anemia. Well, what's anemia? Anemia is decreased red blood cells. Why does decreased red blood cells cause you to be tired easily? Well, red blood cells carry oxygen and iron. You don't have it, you have no energy. A multi. The nurse is teaching about newly prescribed iron supplementation. What should be included? This is one of those questions that you saw in and heard of in pharmacology. What was that? A couple semesters ago, right? But it's something that comes back. So we need to take it on an empty stomach with orange juice. It's extra acid, which will dissolve it like the stomach acid. It helps it make it into a product that the body can use. We drink it through a straw so we don't stain the teeth. The stools are going to turn, it's a nasty looking, greeny, black looking. It's quite distinctive and it's usually sticky. It should not be given with milk because that coats the stomach. It's not going to get the acid it needs. And we take it before meals, not after meals, okay? Very important concept right there. Aplastic anemia includes a depression of which blood cells? Aplastic anemia, pancocytopenia. So this is a child who's anemic, has no energy, has low white blood cells, so is prone for infection, and has low platelets. And now you're going to see bleeding, petechiae, ecchymosis, and it's all together in one diagnosis of aplastic anemia. Most common type of anemia is iron deficient anemia is absolutely the most common, and we usually start to see this in children as early as toddlers, right? Because they don't eat the way that they should. What causes pernicious anemia? So pernicious anemia, or the intrinsic factor, is not enough B12. Remember, if you don't have enough B12, you have pernicious anemia, how are you going to fix this? What's the treatment? Gonna give B12. As simple as that. It's actually a pretty pink purple liquid if you get the IM injections. What symptom is the single most common symptom of anemia? I put a picture up there of absolutely everything you could see. What's the most common? Well, let's go back. What's anemia? I don't have enough red blood cells. No iron, no oxygen. I'm going to be tired. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for, and when we talk about it, we talk the Cooley's anemia when we talk about thalassemia. Unless they're saying different, but everything I see that you're tested on, etc., it's Cooley's anemia. What is thalassemia? The red blood cells burst. Iron and oxygen go into the system, and it creates hypoxemia, and it causes an iron overload. This is a child who's going to be requiring chelation therapy, and they're going to require transfusions to live for life. What lab values will you see with hemophilia? Hemophilia is bleeding, right? So what is it? So the PTT is prolonged, but the PT and platelets are normal. Okay? Just remember that. That's a very important thing. PTT, bleeding time, it's long. PT and platelets are fine. What is immune thrombocytopenia purpura? ITP. P is for what? It's how I remember it. So ITP, decreased platelets. What does that mean? Platelets are used for what? Platelets are used for that bleeding cascade, right? We need it to stop when you are bleeding. So if you don't have platelets, we're going to see that purpura, the petechiae, ecchymotic areas, epistaxis. We're going to see blood from every place. So bleeding precautions. Thrombocytopenia can cause the following symptoms. So it's all about anything with bleeding, petechial hemorrhage, ecchymosis, and epistaxis, yes. It's no rashing, like urticaria is more like an allergic rash that like itches. That's urticaria. A multi. Child with hemophilia has fallen, his knee is swollen and painful. Treatment would include. My 9-year-old boy fell down, came to the ER, and ended up with the factor. What did he do immediately when he fell down? And he got that big bruise that looked something like that. Remember, hemophilia can bleed up to 1 hour after the fall, okay, or more. So it's going to do rice. Rest, ice, contain, elevate. Which one of these works? Elevate cold packs. You're not going to exercise it. It's going to increase the bleeding. If you put hot on it, it's going to increase the circulation and increase bleeding. So that's why it's elevate and cold packs. What is the priority nursing action for suspected blood transfusion reaction? I think I said it 3 times. You know this one. Turn it off. And what we do is we take it, tubing, everything, we put it in a bag and send it back down to the blood bank. A child is admitted with neutropenia. Which nursing action takes priority? What is neutropenia? The whole thing about, okay, neutropenia is decreased white blood cells. You have decreased white blood cells, you're more apt to get an infection. What's the number one priority to decrease infections or passing it on? It's strict hand washing. The rest, maybe, but it's strict hand washing is your priority number one. When distraction is used, it helps. I'll always bring some questions from last week or a week before that I think you need to know, or just to revisit it. And it's a little bit of everything. Distraction basically stops the child from thinking about what bothers them. You know, I used to work night shift. 23 years of my career was night shift. And I've told my class, but I used to every night go into all the rooms and turn on the radio on just one of those little mellow rock type stations, but nothing, crazy, just very mellow music. I'm telling you, the whole unit used to sleep every night I was on because it distracted them from thinking about the bings and the bangs and the monitor and what was going on. So distraction is excellent, whether it is putting that music on, giving them an iPad, turning on the TV, giving them a pack of cards, crayons, anything. Distraction really, really works. What assessment question needs asked to a child with possible rheumatic fever? So rheumatic fever comes from a sore throat, which is strep. How do we treat rheumatic fever? Now, rheumatic fever is a whole conglomeration of diagnosis, right? It has rashes, polyarthritis, has sore throat, it has mitral valve damage, and everything. And then it's chorea, that movement. You can't control your movements. Now, everything can be reversed, but that valve, that mitral valve, that was damaged, we cannot correct that. It's going to have to be corrected with medical management or surgery. Signs and symptoms of asthma. Not letting you forget last week, am I? You have an exam next week. That's why I put these in here. So asthma, it's you're coughing and you can't control it. You're short of breath. And the big, big, big thing of asthma is that expiratory wheezing, right? All the other stuff in respiratory, croup, epiglottitis, that's all inspiratory stridor. Asthma, air gets caught in the lungs. So you get air in, but I can't get it out. So it's trying to get it. Very good. A multi. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? Which ones are the bad ones? I mean, some we all get with everybody. We have common signs and those that are dangerous. So headache could be a stroke, and chest pain could be pulmonary embolus, right? It is normal, swelling hands and feet. It is normal, those sores that do not heal with sickle cell. So the ones that need to be reported, maybe immediately, I should put in there, is the chest pain and the headache. What are the odds two sickle cell carriers would have a kid with a sickle cell? It's 25%. Very good. Position for a lumbar puncture, an infant or a young child patient. What would you position them like? So it's called lateral decubus or fetal position. That means on your side and you're all bent over. Now, bent over a pillow sitting, that is not young kids. That's older adults, adolescents. The younger children on their side, their knees up to their chest, and we can just hold them and give them a big hug for it. Hodgkin's or non-Hodgkin's. Diffuse cancer of lymph tissues is what? Diffuse. You can't see them, but their lymph tissue is full of swelling and cancer. And the answer is when it's diffuse, it's non-Hodgkin's. And let me tell you how you're going to remember this, because this is the way always quiz and exam questions add up. 50% are right or wrong. Okay. If you are Hodgkin's lymphoma, you have a Hodge, a lodge, a house, something you can see, feel, touch. It's above the shoulders. Usually the neck has big lymph nodes sticking out, okay? If it's not a Hodge, a lodge, that means it's spread out all over the place. Diffuse cancer, it's non-Hodgkin's. Can that help you remember those now? Wilms tumor is So Wilms tumor is a mass on a kidney, and it is extremely fragile. And our concerns always is the handling of that tummy and to prevent it from metastasizing because it will break off and it will go other places. So a child has Wilms tumor. What action by a nursing student causes a faculty member to intervene? What'd she do wrong? What did I just tell you about Wilms tumor? It is fragile. It's encapsulated. We don't do anything to poke it. We don't do biopsies on it. And we don't touch it, as in do not palpate the abdomen. So if we see somebody touching it, we're going to stop them and we'll tell them why, because you probably will break a piece off and it will metastasize. Absolute contraindication for nasal tracheal suctioning include which of the following? So whenever you have anything in the oral pharynx that is swollen, you don't ever want to mess with an airway. So epiglottitis, croups, status post, any tonsils, adenoids, anything. We do not want to put anything in that mouth to increase the swelling. Iron dextran is given via which route? This was actually the first injection I ever gave as a brand new student. And it was scary for me because I had to give IM Z-Track. Can you imagine your first IM injection was a 40-year-old lady and I had to do it, pull it up, give it, out and put it, I call it the lock and load Z-Track. And actually the lady said I did an excellent job. She didn't even feel it. So that's how I started my nursing injections. What cancer may present with painless, firm, and enlarged cervical nodes? I just told you all about it. And that is Hodgkin's lymphoma. Very good. A multi. When teaching about sickle cell disease, you would include what? So sickle cell disease, you need to have fluids like crazy, keep everything dilated, all the blood vessels. Yes. Pain medicines, take them early. They usually give them Tylenol number 3, the pills to go home with to start if they start with pain. Again, if it's cold, we want to keep them warm. And then any immunosuppressed child, whether it's leukemia, whether it's sickle cell, any child with 100.5 fever, it will always be recommended call the doctor, get medical care, because you have no immune system to fight it. Okay. That's always any of those immunosuppressed. Those as a concept you're going to see. And thalassemia major is treated primarily with what? Thalassemia major, Cooley's anemia, is just blood transfusion. Nothing else works. And why would you give high iron diet to a child whose iron's burst into their blood system and they're toxic already? It would be, can you give a low iron diet? I guess no spinach. What is the most common opportunistic infection for children with HIV? It's the last question. Most common opportunistic infection, HIV. And it's pneumocystic pneumonia, PCP. Yes. All right, let's see how we did. Number 3, Jay. Number 2, Brittany. Good job, Brittany. Number 1, 2, Mariah. Good job, Mariah. And Meg and Kev. Boy, had a good showing there. Good job, guys. All right, we're going to continue on. And I'm going to be doing the cancer section now. We did do some of them already. Give me 1 second. Okay. All right, child with cancer. We've had a couple of the questions. I'm going to hit you again here with them, but I think it'll work out well. Neoplastic disorders. Most children with cancers is usually leukemia or lymphomas. Usually it's not, the brain cancer, lung cancer, liver cancer. No, it's usually leukemia and lymphomas. What is leukemia? It is a complex disease where your white blood cells are attacked. That means you have no white blood cells. You can't find infection at all. More common in boys and Down's children, poor Down's children. So we have hypothyroidism, congenital heart disease, and leukemia are all high list on Down's children. So you get a child with Down syndrome in the ER with bruising and pain and all of the symptoms. always check the CBC. This child could be leukemic with Downs. So we call it an unrestricted proliferation of immature white blood cells in the blood forming tissues. Again, we know that has to do with you absolutely have no immune system to be able to fight any sort of infections. So how do we diagnose this? Well, usually it's by history and by looking at the child. You know, I describe it well. I had a neighbor who's had a young girl and she went to the ER. She was complaining of fatigue, flu-like, no energy. She had some bruising that was not normal because she didn't go out and play like that. And she was having really bad bone pain, especially in her knees. She came into the ER and they did a CBC. Of course, whenever you're concerned, you have this fever, you have this bleeding stuff going on. All right, let's do a CBC. Well, they did the CBC and they confirmed that she was leukemia. There are two types of leukemia. There's ALL and AML. And all you need to know is the ALL is the easier of the two to cure. AML is a little bit harder, okay? Now, once we determine that we have leukemia, they're going to be doing a lumbar puncture. So you got to get that child prepared for that, right? It's going to hurt, but be honest about it. And that's going to be looking at the cells, see what's going on in the bone marrow. Once we get all of that stuff and the testing's done, we're going to be, and we insert some sort of port, some sort of central line in order to start giving chemotherapy. Now, it's interesting that the first 4 to 6 weeks, they give whatever chemo they need. Could be 2 types, 3 types, 1 type, depending on the doctor and the newest up to date, whatever they feel. But they do what we call in the first 4 to 6 weeks, induction therapy. By the end of 6 weeks, you're in remission. But they keep going on because there could be some cells hidden somewhere. So they do the central nervous system, then they do the whole body with a little extra more just to be sure that there wasn't anything resistant in there that didn't want to, that cancer go away. And then they do maintenance just to make sure that the cancer doesn't come back. So induction therapy, first 4 to 6 weeks, the goal is remission. Now, many times when they have leukemia, they opt to have a bone marrow or a stem cell transplant. Now, there's different types of stem cell transplants. Now, you don't have to have the same blood type. You don't have to be a relative, but if you have your own blood is saved, and it could have been the umbilical cord blood that mom saved, said, oh, just to be sure, let's save it, or they saved some other from another time, we can use that. And automatically, that's the best. That's autologous because it's a no-brainer. That's the best I should have. Okay, now all the other people that gives stem cell transplants is called allogenic. It's all the others. So automatically, autologous, mine is the best. Allogenic is all the other people. Again, it doesn't have to be my blood type. It just has to match in whatever way they do the matching. Now, with leukemia, as I said, it's intense, and they're going to be putting in a PICC line or a port in order to draw bloods. When the child is having some sort of infections, which happen during this time, we can give antibiotics right away. So again, this child's going to be going through a lot in the hospital, a lot. They're in pain, they're miserable, they're weak, they're tired, and it is many complications can occur. So remember, their white blood cells are non-existent. So infection is the big, big worrisome complication. of course, as I said, platelets are going to drop because, when you're giving treatment, chemotherapy, even the cancer is going to eat some of the platelets. So you have to be watching for bleeding precautions, hemorrhage. Another thing is the red blood cells. They're also going to be eaten up and you're going to have anemia with them. Now, being a chemo nurse, being an oncology nurse is a really difficult job. But I want you to know that I've seen ads for nurses who have 1-2 years experience that are chemo certified, that if you do these sign up bonuses, it's like $25,000 for a 2-year commitment just for this position. Now, it is hard. Children die with it. But, I never look at it that children died. You know what I looked at it as? These are kids that I can make happy if it's their last couple, months or years or days on life, right? I can be there to give them and the family something. And that's what I've always felt. Even if they died, what did I do for them before they did? Now, prognosis of leukemia. How do we know, is it going to go good or it's going to be rough? Well, what was the white count? As in, my girl that went to the ER was 0.1 was her white count. Usually it's 7 to 10, something like that, 0.1. Now, what if it's 0.01? Now, that would be harder to cure than the other. So initial white count. How old were you? Younger kids do better. And then was it ALL or AML? Are you a boy or a girl? And then karyotype. This child's going to be receiving blood transfusion, platelet transfusions, and it's going to need blood products. If you have a rare blood type, it might be harder to get those products on time, and that may make the prognosis a little poorer. So chemo, we do many different things for cancer. We do chemo, radiation, and we do surgery, right? Know that what do we do for what child? It all depends. Depends, do we do radiation? Are the kid old enough? Can they handle it? Or are we just going to do chemo and surgery? Whatever it is, they have to figure it out for the age of the child and if they can tolerate. So figuring out if you have cancer and detecting it early, getting treatment early is what we want to do. Some of the signs and symptoms, and I've mentioned some of it: pain, fever, ecchymosis, petechiae, bleeding, right? Platelets are low. Fever, no white blood cells. Lethargy, weight loss, general malaise, anemia, lymph nodes. They're going to try, your system's going to try your immune system, and they are going to get swollen, but doesn't mean they're going to work. And sometimes even your vision. Now, during chemotherapy, we are going to eradicate the white blood cells in the body. We're trying to get rid of all the bad stuff. Well, as we do that, we are going to be decreasing all those neutrophils. Neutrophils, white blood cells, are there for infections to help fight them, right? Now, just because a child is with cancer, we'll be looking for neutrophil counts. But any child, doesn't matter if they have cancer or not, any child with a neutrophil count lower than 500, this is going to be your priority care. This child is about to go into septic shock. There is no immune system there, and especially if they have a fever. They have a fever, low neutrophil count, that's a setup for disaster. That'd be the one that we would see first and probably move into an ICU if they're not in one. When we're looking at these children and infections, we'll always do the collection of the specimens, the urine, the blood, the sputum, whatever, everything we'll be testing. Broad spectrum antibiotics will be used and to try to help the body. And our goal with this treatment during this whole time. And it's hard because we're eradicating that whole, you know, white blood cells, red blood cells, the bleeding and infections are great. But our goal is to try to keep infections away. And again, it starts with hand washing. So hemorrhage is something that can happen with those children, like I said, low platelet counts. So again, everything we do is going to decrease the amount of bleeding that can occur, right? Teach the child at home. They shouldn't be out riding a bike, skateboards. They shouldn't be out playing football or any of those things. We know that they're going to be anemic because the blood cells are low. So again, set up activities that don't require that much energy, and always do cluster care, making sure we're not over tiring that child. Nausea and vomiting is big in chemo and getting the chemotherapy agent, right? You know, when I started nursing, we couldn't give an anti-nausea drug until that patient vomited, which is ridiculous, isn't it? But I used to say they're nauseous. All right, let me go get it. Oh, they vomited a little in their mouth. All right, I'm giving it. But today we realize 30 minutes before a child is going to get chemo to give any pre-drugs, and one of them is an antiemetic. Their mouth can get full of sores and stuff with them. So, and with chemotherapy, they're just overwhelming feeling of being tired and not feeling good, right? So they're not going to eat good. So high protein, high calorie, load the fat in there, because every little bite we want to make a difference. And how are we going to be monitoring if we're keeping up with nutrition? Simple. Daily weights. Daily weights will tell you, are they gaining weight, losing weight, right? As I said, that mucosal ulcerations are there. So using foods that are not going to burn the mouth. They don't like lidocaine in there because it can, you know, numb the throat and cause you gagging, choking, aspirations, etc. But again, working around that to try to get them something to eat is the important. No neurological problem. So you've got a child who doesn't eat, who's in pain, who's getting pain medicines, who has a really good chance of becoming constipated. What do you do when you're constipated? You bear down and you push hard. What? You have to be worried about the brain, because you could have, because low platelets, bleeding. So you got to be making sure we keep that stool as loose as we can. So stool softeners are going to be there. They can have hemorrhagic cystitis. Again, just watching it, making sure. And I think one of the most common is hair loss. You know, I used to go and get these little rolls of ribbons, all the colors, yellow, green, purple, white, black, green, didn't matter the color. And I would take and make little ribbons and little headbands for my little girls. And I would take and put a little ribbon in my hair because they were my girl today and I wanted to be matchy match. And I'm telling you, with the hair loss, it didn't make a difference because they had a pretty bow in their hair. I've also seen parents, I've also seen brothers, uncles, next door neighbors, friends, also cut their hair to be the same as a little girl. Another thing we don't think about is we give a lot of steroids in cancer. Again, there is that Cushing type disease where they swell up all over and they become even more concerned about their image. So getting ready for procedures. Well, first of all, I told you, be honest. Just be absolute honest if it's going to hurt. Many of these procedures, even like the bone marrows, they probably will give some sedation, something to keep them calm. Again, explain it on their developmental level and making sure that we're using topical and deep infiltration anesthetics to numb the area to as best as we can. Pain management. One of the things about pain management is sometimes it's just positioning. Sometimes it's a hot pack, a cold pack. Sometimes it's just sitting there listening and distracting. Health promotion. Well, kids with leukemia, do we still need to be concerned about all of the other things like dental care? Oh, yes, we do. Now, we still want them to get examinations. They still want them, to use, good mouth care and flossing their teeth. Absolutely. Now, immunizations. Do we give immunizations to children with cancer or immunosuppressed due to chemotherapy? Well, live vaccines are not used. Another time live virus vaccines are not used is if you're on steroids. You are considered immunosuppressed. So immunizations and cancer live, no, we don't give them. We can give inactivated vaccines. That's not a problem. Family, you got to be concerned about too. Not all of them they can get because you're close to the child. And the one thing that they really need to get is that varicella vaccine. Varicella is dangerous for a child on chemotherapy. All right, here's that question on those Hodgkin's and non-Hodgkin's. I forgot to flip it over to this other PowerPoint, but that's okay because you're going to remember it better now. So, Hodgkin's lymphoma. Hodgkin's lymphoma is this large, above the shoulders type of lymph glands, okay? You can see it, you can touch it. It's a Hodge, it's a lodge. I can see it, right? Okay? The problem with these big lymph nodes getting larger is pushing against the airway. So all of a sudden you'll see this coughing because it's pushing the airway, all right? With that, these children, because of this pushing, they become nauseous, they get anorexic, and they get weight loss. So how do we treat this? Well, they do a biopsy. This one you can biopsy. On your kidney one, you can't. So we're going to do radiation. We're going to do chemo. And when we're giving radiation, those little purple marks, remember, we can't wash them off because the radiation has to be put in the same place every single treatment. Chemotherapy is then done, and then they can do surgery and they can get rid of it. The thing with Hodgkin's, because of the radiation, because of the chemo, there's a high risk for infertility in children. Now, non-Hodgkin's are not a lodge, which means it's poorly differentiated. I can't see it. I can't feel it. It's in the body. It's harder to see, okay, because of all of that movement around. So again, we try to go do a biopsy, find it. We're going to try to diagnose it, and we will get rid of it, usually with the chemotherapy. Now, brain tumors. Brain tumors are not that, it's of all of the solid tumors, the most common, but as I said, brain tumors are not that common in children. Now, in children that have a tumor in their brain, what do you think you would see? Well, that tumor is occupying a piece of space. It's smushing everything around, right? So headaches. Because of the extra pressure in the head, vomiting. What if it's up by the eyes? Nystagmus can occur. Any eye problems, movement problems. Because it's in the brain, depending where it is, could be a problem with the movement in your hands, right? Also, diabetes insipidus. Diabetes insipidus is in the brain, the pituitary gland. It could be pushing there, and it could create that. You'd see the drinking and urinating a lot. And it could go by where the growth is trying to grow. You could have growth failure. So how do we diagnose? How do we do these children? Well, we're going to look at all the clinical signs. It could be that they're falling over. It could be that they have severe headaches, vomiting. It could be any of those things that are showing you. So we'll do the x-ray, the CT, the MRI. We also will not do a lumbar puncture. If you do a lumbar puncture with somebody with a brain tumor, there could be extra pressure there, and it could create a lot of that cerebral spinal fluid to be removed, and then the brain shifts, and it could be a big problem. So we do not do lumbar punctures with brain tumors. A lot of times, if we can, depending where they are, we'll do a biopsy. So these children, when we have a brain tumor, so sometimes they have these big incisions over their head. Make sure you know, can you elevate the head of the bed? Or do you have to keep them flat? Can you put them on the operative side or the right side or the left side? All of these things are important. And one of the most important things to monitor in these children is fluid balance. Too much fluid will put too much pressure in that brain and cause more problems to occur. This picture here is a picture of a brain drain. You see that tube that's sort of in the head? And a lot of times you do have them. Do you touch it? Do you empty it? Or do you leave it alone? Again, these are all things you must check. You don't touch it till you know what you need to do with it, okay? Neuroblastoma, we don't see much of these, but this is a little baby's picture where it was in the abdomen. Usually it starts with a kidney and it goes off into the brain as a metastasis. And then all of a sudden you see the abdomen big, which makes you go looking. And then it's too late. It's already in the brain. Neuroblastoma, nephroblastoma. Nephroblastoma becomes that neuroblastoma. So with the neuroblastoma, many times we're going to have to do surgery, remove it. Sometimes we can, sometimes we can't. Again, some of them do well and some don't. Bone tumors. Bone tumors, the one that I'm going to talk about is a osteosarcoma. Bone tumor, right? Bone tumor that's in the leg, usually in the upper leg, all right? The bone gets some sort of tumor on it, and it could be, it looks like a little shadow, not much. I've seen bone tumors, some documentaries on athletes where all of a sudden they were having troubles walking or complaining of knee, and they went and they looked, and it was actually an osteosarcoma. Now, you go in, you look at this, you see the symptoms, which is the pain, which is increasing. And then, of course, it's a cancer. So it's going to start eating the body and the blood, anemia. You're not going to feel well. It's going to be weight loss. You don't have white blood cells. It's a cancer again, right? Infections. So with osteosarcoma, our goal is to get rid of the cancer. And you can't just take out that bone, that little piece of bone. You can't. The whole bone has to come. So that means that a child is left with no leg. So what they try to do is they take the lower leg, turn it around, and they put it back up in the hip where the upper leg was. It's called a limb salvage. They salvage the limb. Now, it's backwards, but it's something, someplace to put a prosthesis. And that's the way they do it now. They used to just take it all off, but then how are you going to put a prosthesis? There's nothing to attach it to. So now they do this turnaround and they put a prosthesis and these children get around. There many times are adolescents. It's a really hard time to lose a leg from all that identity and body image and all of that. Wilms tumor, I've already mentioned it. Know that Wilms tumor can, Wilms tumor, again, is that do not palpate. Even preoperatively, we don't even stick a needle in it to do a biopsy because all of the chance of that cancer getting out inside that abdominal cavity, and we don't want to do that. So we don't touch it, we don't do biopsies, we do the surgery. Once surgery is done, now that surgery, and I showed you that picture that is a real picture of a child who's just had a Wilms tumor taken out. You can see the whole abdomen was filleted open. Where are the kidneys? They're in your back. So all through those intestines, they got to get way down to the bottom. So you can imagine post-operatively, you need to monitor their bowel function. These children go into an ileus, which means they stop working because of the heavy manipulation of all those intestines. Also, you're taking a tumor from a kidney, so you're going to monitor for urinary output, right? Retinoblastoma, pretty neat thing. Do you see that little picture of that little white eye? It's also called a cat's eye. And ever see at nighttime, you look outside in the field, if you're by a field, and you see an animal and you see the shiny eyes? That's why we call it cat's eye. I've only seen one of these in my career, and it was like an 8-month-old little girl. Now, it is cancer, and the eye has to be removed. Some of the things preoperatively that you would ask is, this 8-month-old girl that I saw, did she have any eye problems before? Has she had frequent eye infections? Have we seen drainage? What was going on? That would be really important of the assessment. These children will get irradiation. And again, you see the purple mark? Don't remove it, leave it there until it's done. Okay. And then they'll do chemo with it, and then they'll do surgery. They'll take out the eye. Now, once they get the eye out, they can put a prosthetic eye in there. As a story, I had a kid in high school who used to take his eye out and roll it around the desk just to have all the girls scream. It was what he used to do. I'll never forget it. But he'd take it out, roll it around, then he'd put it in his mouth, get it wet, and put it back in. And I'm like, oh my God, I don't believe you just did that. But the kid obviously was well adjusted with it. Now, germ cell tumors. This is that monthly check for men. Check your testicles, making sure there's nothing in there that doesn't feel like it shouldn't be there. Women do breast checks, men should do monthly testicle checks. I had a little boy, it wasn't little, he was 18 years old, who came in to the triage one day. And the other nurse had him and complaining of testicular pain. So she said, okay, let me see. Well, the testicle was the size of a softball. She goes, oh boy. So we took him inside. We did an x-ray and we did an ultrasound of the testicle. The x-ray showed multiple cancers everywhere. It metastasized everywhere. And of course, the testicle was full of it. This 18-year-old child died about 3 months later. I don't know how long he had this testicle in pain and enlarged, but testicles and cancers is a big deal. Liver tumors are actually not that hard because livers grow back, so they could take out the piece. And then let's look at cancer today. Every time I look at this, the survival rate goes up because of all the new treatments that are going on now. And we're looking at so much to try to turn around that children and adults don't have to live with cancer. We'd love to have a cure in it, but it's going to take some time. And that's what I like to see in Facebook. Give me a cancer-free. And that's because a kid has fought it so hard. All right, let's go back to our Kahoot. Any questions? That means ready to go. All right, let's get going. What is a priority nursing action for a suspected blood transfusion reaction? The extra 5 times already. I think you know this one. Absolutely, just stop it. Ashabash is back. A child is admitted with neutropenia. What nursing action takes priority? Absolutely, it's hand washing, right? Neutropenia, low neutrophils. That means no immune system, no white cells. We're going to wash hands. It's always number one. Which symptom would a healthcare professional expect to see in a child with leukemia? And these are exactly those symptoms that my neighbor had when they found out she had ALL. And it's bruising because platelets are low, fatigue because blood cells are low, and cancer always, leukemia always has pain, and she had that knee pain. Your child with ALL has had recent lab results with a platelet count of 10,000. Nursing action. What does that mean, a platelet count of 10,000? What does that mean to you as a nurse? So no platelets means they're gonna bleed, so you're on bleeding precautions. Very good. Excellent. Child with Wilms tumor, which action by a nursing student causes the faculty member to intervene. Yep, we're not gonna touch that abdomen. We're not even doing biopsies on it. It's very fragile. A child with ALL has a fever of 100.5. What should they do? Mom, I got a fever 100.5. What do I do? Right? If I have ALL, I don't have an immune system. I need medical attention because I need to start antibiotics now because these children have nothing to fight with. Child is having a bone marrow aspiration. What should you tell the child? It's not going to hurt. No, never say that. It's going to hurt a little bit. I'll do everything I can to make it as easy as possible. Would you like to hold your stuffy bear? Right? Most common clinical manifestation of a retinoblastoma. And remember, and in the end, treatment is they've got to get that eyeball out. It's sad, but it happens. It's called cat's eye reflex. Your child's been diagnosed with a retinoblastoma. What information is important? What do you have to ask? What's part of that assessment? And it's all about anything been going on, those any signs, any symptoms, not just infections, but there could be pain, there could be something. I want to know everything about the eye, anything that was different. A goal of surgery for a child with an osteosarcoma is what? That femur bone has a cancer in it. What do I need to do with it? So the goal of osteosarcoma is to salvage the limb to use a prosthesis, which means you take off the femur, that's gone. You don't remove a piece of a bone. The whole femur has got to go, all right? All you're left is the lower leg. We want to take it, put it up and reattach it because we need somewhere to put a prosthesis so we can walk, be active. A child's complaining about those skin markings for radiation therapy. They should be told what? Those markings are so important. They do a lot of measurements in order to put that mark down. So they need to stay there. We used to, in some of the kids, we would do these parties, we'll be washing them off parties and have a birthday cake for them of washing off that purple marks that we didn't like. Got to make fun out of little things. When distraction is used, it helps what? And we know it gets rid of them thinking about what's wrong and what hurts. What assessment question needs to be asked with a possible rheumatic fever? And remember, rheumatic fever is because of a strep infection. How do we treat it? We treat it with an antibiotic that was for the strep. Rheumatic fever, the one thing we can't treat is that heart valve damage. If it's damaged, it doesn't bring that back. Signs and symptoms of asthma. Again, it's that coughing, it's that shortness of breath, and it's that expiratory wheezing because air goes in and it gets trapped. A multi. What symptoms should be reported to the healthcare provider for a child with sickle cell? Now you're going to know this one. These are the dangerous ones. And it's the headache and it's the chest pain. Excellent. Absolute contraindication for nasotracheal suctioning include which of the following? Again, nothing in the mouth. If you've had surgery or there's swelling, anything, you don't want to disrupt it. You need to maintain that airway. And iron dextran is given which route? Again, it's IMZ track. A child is to receive their own bone marrow. This is called a blank transfusion. It's automatically mine is the best autologous. Excellent. I hope you remember it that way. What cancer may present with painless, firm, enlarged cervical nodes? I can feel them, I can touch them, I can see them. And that's Hodgkin's lymphoma. Excellent. A multi. Treatment of osteosarcoma includes so treatment of osteosarcoma, the absolute best is that salvaging of limb. But if we can, we're going to start chemo. Of course, chemotherapy is part of it. And if we can't do that salvage, we're going to just amputate the whole leg. We don't want to, but we can. A stem cell transplant, that's not done for anything with this. That's more for your ALL. A multi. Who are the best donors for bone marrow transplantation? So we know absolutely the best one is always yourself, okay? The second best is the siblings. You actually see some parents go have another baby to try to get that cord blood to use it on that child who needs it because nothing else is working. You might see it. So it's both of those. Can the other ones be used? Yes. But best, yourself number one, siblings number two. What is the most common opportunistic infection for children with HIV? And it's pneumocystic pneumonia. That's number one most common. What would you consider to be neutropenia or a low neutrophil count in children? Remember, any child who's neutropenic with a fever, that will always be your priority to take care of that child. Whether they're leukemia or just a kid in with a headache, doesn't matter. They're neutropenic, fever, it's scary. Less than 500 is that. It should be about 2,000, the normal number, somewhere about that. A primary characteristic of a brain tumor is, so remember, you get a tumor and it grows. So it's symptoms that become worse over time. It is vomiting, not related to eating, just you vomit, okay? And it would be headaches that got worse and probably wakes them up at night. The optimum treatment for the osteosarcoma is? And it is salvaging the limb. Remember, the femur bone must be completely gone. The whole bone has cancer in it. So you can't just take the little piece of whatever it shows you. The whole bone has to come. So take out the femur and the lower leg is salvaging the limb. And last question. A child is receiving the induction of chemotherapy. What does it mean? And that's usually the 4 to 6 weeks. So it's 4 to 6 weeks. It's that initial, they hit you with big time chemotherapy. The goal is remission, but we continue because we want to make sure we caught all the little cancer cells that are hidden and that don't want to be taken away. Number 3, Mariah. Good job, Mariah. Number 2, Kevin B. Good job, Kevin. Second time up there. Number 1, Jay. Good job, Jay. And we got okay, we're good. All right, well, this is the end of today's class. Thank you for your patience. Sorry about my internet driving you a little bit crazy earlier. Know that this week is all of our exam reviews. Next week is the exam. I am giving my review tomorrow at 4 o'clock if anybody wants to join. If you don't want to, can't see it, don't want to wait for your recording to be given to you, you can always go to YouTube, Professor Bogart, Pediatric Nursing, and all of my stuff is there. You can listen to it as soon as you'd like to, okay?
Thank
Nice meeting
you.
you all. Thank you so much, guys. Have a good day.
Thank you.
My pleasure.